welcome everybody. My name is Kristen Kidd, and I'm one of the coordinators at the Southeast Prevention Technology Transfer Center. And we're really excited you could be here today to hear about fetal alcohol spectrum disorders in the Southeast. Okay, so the disclaimer is that this training and the Southeast Prevention Technology Transfer Center is 100% supported by SAMHSA, the Substance Abuse and Mental Health Services Administration. The contents that you're going to hear today, the views and positions, are those of the presenters and are not necessarily representative of the official views of SAMHSA or the Health and Human Services or the U.S. government. So the PTTC network is, we believe it's very important that we use inclusive language. And inclusive language is the recognition that just basically words matter, and that your word choice can be used to intentionally or unintentionally include or exclude others. And really, using inclusive language communicates in a way that's respectful and brings everyone into the conversation. So this is the PTTC network. I'm sure the majority of you are quite familiar with the PTTC network now. There are 10 regional centers around the U.S., and we are in dark blue. The Southeast Prevention Technology Transfer Center is housed at Wake Forest University School of Medicine. We're under the direction of our co-directors, Drs. Mark Wolfson and Kimberly Wagner. We serve 8 states in the Southeast region, from North Carolina down to Florida, over to Mississippi, and up to Tennessee and Kentucky. So these are our presenters today, and I'm going to ask Dr. Wolfson, one of our co-directors, to introduce them and sort of set the stage.
Thanks so much, Kristen. Can you hear me okay?
Sure can.
Terrific. Well, we're really excited about this webinar today. Thank you all for joining us. It's great to see people from all over the Southeast, all over the country, and all over the world. I see somebody from Paraguay is participating for this webinar today. And part of the reason we're excited about this is the topic, and which is fetal alcohol syndrome disorders. And this is really an important topic, as you'll see from the presentation today and discussion, a really important topic for prevention and for public health. But for a variety of interesting reasons, it's a bit of a neglected topic, I believe. So we're really delighted that we can offer this webinar to shed some light on it. We're also excited that the webinar, at least in part, it'll give you a global perspective and a national perspective, but also a perspective on the Southeast United States, which is the region that our PTTC primarily serves, as Kristen pointed out. We're also excited because our presenters represent the leading research group, in my opinion, in the US on fetal alcohol syndrome disorders from a public health perspective. So you're really in for a treat. So a few words about our speakers. Dr. Julia Haskin is a postdoctoral research associate at the University of North Carolina at Chapel Hill. And she's worked over the past 10 years on epidemiological studies on fetal alcohol spectrum disorders. And she's authored over 25 publications focused on prevalence, child characteristics, and maternal risk factors of FASD, both in the US and in South Africa. And our other speaker is Dr. Philip May, who is a professor at, again, at UNC Chapel Hill in the School of Public Health. And he has over 25 years of experience on research on fetal alcohol spectrum disorders. He has a number of awards and distinctions. He was a member of the groundbreaking Institute of Medicine, IOM, study committee on fetal alcohol syndrome. And he's received a number of awards from NIAAA and others. He gave the Mark Keller Honorary Lecture at NIH in 2018. He's received the Henry Rosette Research Award from the Research Society on Alcoholism, and an Excellence Award from the National Organization on Fetal Alcohol Syndrome. He perhaps even, well, I won't say more importantly, but I'll also point out that he is a proud graduate of Catawba University in North Carolina for his undergrad, and Wake Forest University for his master's degree. I'm also pleased because I've known Phil for over 20 years now. So with that, let me pass it off and ask Phil and Julie to take it away.
All right. Well, hello, everyone. I'm happy that Mark and Kristen have asked me to make this presentation. And it just so happens that what I'll be presenting to you is part of a paper that we had completed 2 years ago and published 2 years ago, just on the Southeast portion of our national study in fetal alcohol spectrum disorders for NIAAA. All these studies were funded by the National Institute on Alcohol Abuse and Alcoholism, and we have no other financial disclosures or conflicts of interest to report. So we're going to have 5 different parts of this presentation. The first part is what are fetal alcohol spectrum disorders. It's an umbrella term, and we'll briefly review the 4 different diagnoses that exist under that umbrella. 2, we're going to explore FASD in South Africa, or at least introduce you to that topic, because the epidemiology of fetal alcohol spectrum disorders has been advanced farther in South Africa than any other country in the world. And we are fortunate to have been the PIs on that for as long as it's been ongoing, 26, 27 years. And 3, we're going to talk about the COFASP initiative, which was a collaboration on fetal alcohol spectrum disorders. And it was a study designed to determine the prevalence and characteristics of FASD in the United States. Then I'll go into details about what we found in the Southeast here. And 5, we'll talk about prevention and intervention and how some of the topics which link nicely to prevention and intervention efforts. So fetal alcohol spectrum disorders, as classified in 1996 by the Institute of Medicine with a special committee, which met from 1994 to 1996, has 4 specific diagnoses. One is the most severely dysmorphic and the most severely affected children in terms of neurobehavior and physical growth and development is fetal alcohol syndrome. And fetal alcohol syndrome was not a diagnosis. It wasn't really discovered until 1973 in the United States. There were some inklings out of Europe as early as 1968 that there was such a thing, but it took a diagnosis made by David Smith and Ken Jones at University of Washington to fix the criteria for the diagnosis. The Institute of Medicine also expanded that to partial fetal alcohol syndrome, alcohol-related neurodevelopmental disorder, ARND, and ARBD, which is extremely rare, alcohol-related birth defects, which are physical defects that come from specific exposures at specific times in the pregnancy, but do not have a neurodevelopmental aspect to them. In other words, the child is generally in fine shape neurobehaviorally, but there are several major physical defects that could come up, and that's an ARBD. Now, when the diagnosis is made, all the clinicians who are skilled in this diagnosis rule out all other known anomalies before the final diagnosis of FASD is made. In other words, they assure that there are no other phenotypes at play here and no other causes like marijuana exposure exclusively, or other types of teratogens. and also they're not manifestations solely of genetic disorders. So anyway, it's a diagnosis of exclusion. Now, a lot of people make the diagnosis completely on the face, and these are just the facial features that are common with fetal alcohol spectrum disorders. There are heavy epicanthic folds to the eyes. There's a flat nasal bridge. The nostrils of the nose are often anteverted, and the bridge of the nose is quite flat. And there's a very smooth upper lip, no philtrum, and there's a thin vermilion or red border to the child's face. But there are 37 different features that our clinicians use to diagnose fetal alcohol spectrum disorders. So it's much more than the face. And all of these facial features have been used because they're indicative of poor brain development. Poor brain development is the hallmark of what causes the neurobehavioral deficits or problems that we see with children with fetal alcohol spectrum disorders. And on the screen, you see 4 different children who have fetal alcohol spectrum disorders. Most of these are full-blown fetal alcohol syndrome. Fetal alcohol syndrome tends to be about 10% of the diagnoses these days within the spectrum. Basically, the cause of it is that fetal alcohol, that essentially the mother and the fetus have essentially the same peak blood alcohol concentration. And the quantity of alcohol that is consumed in the prenatal period, the frequency that it's consumed, and the timing during the gestation of the fetus are what cause the various forms of fetal alcohol spectrum disorders and the severity of the traits that wind up in the child. And the reason for that is that alcohol is a teratogen, that is an agent that will cause birth defects if enough alcohol is present to cause deficits in fetal development. Okay, that's a very quick overview. I'm sorry we can't spend the whole hour on that. But anyway, 2, research in South Africa, as I mentioned earlier, has been ongoing since 1996, and it's where we have learned the most about epidemiology. We've advanced the diagnostic approaches and criteria there, and we've learned a tremendous amount about maternal risk and protective factors. And we can use these epidemiological data to better understand the etiology or cause of FASD. We've had exceptional people working on our teams. They're multidisciplinary teams, people from a variety of disciplines, from general public health to social work, psychology, pediatricians, pediatric geneticists, pediatric dysmorphologists, and a few of us epidemiologists collecting all the data as it goes into. It's not easy to work on this topic anywhere. Nobody wants to hear that their child may have fetal alcohol spectrum disorders, and information from the mothers sometimes is hard to get. In South Africa, there you see the warning sign in the middle. Our interviewers had to pass a number of signs like that in order to go interview the mothers. But the mothers, once we got to them, were very forthcoming and honest. And so we've learned a tremendous amount in South Africa. We have co-investigators in South Africa. Charles Perry and Soraya Sedat are our current ones. They're with Stellenbosch University School of Medicine in the suburbs of Cape Town, which is in the upper right-hand corner there. Dennis Viljoen, to the left there, was the first South African to come to the United States and say, hey, I think we have a huge problem with FASD. And he made the rounds talking to NIAAA, to CDC, and a number of birth defect scholars in the United States, whom he already knew. And he convinced NIAAA to fund the studies in South Africa. Anna Suzanne Murray down at the bottom left there, Marlene DeFries at the bottom right, and Qdor Snell are all South Africans who have been our program managers, our program coordinators, and Dr. Snell is actually from one of the towns that we've worked in for 25 years, and he's a provost at Howard University in Washington, D.C. So the severity of dysmorphology varies greatly. You can expose a fetus to similar amounts of alcohol, but depending on a lot of other variables like genetics and individual metabolisms, the physical growth and development will vary greatly. The appearance of the physical phenotypes will vary greatly. Cognition and behavior will also vary greatly. So you never really know. It's not a straight X exposure creates a Y phenotype. It just doesn't happen that way. There are many, many variables that intervene and are cofactors in the level of disability that we see. As I mentioned, section number 3, I'm going to tell you about the U.S. initiative to determine the prevalence and characteristics of fetal alcohol spectrum disorders. And it was also funded by NIAAA from 2010 to 2018. There are a number of publications that have come from that, including one just on the Southeast, which we can make available to you. Our co-investigator with this was Tina Chambers from the University of California, San Diego. The 4 regions that we did our studies in were Southeast, Midwestern, Rocky Mountain, and the Southwestern Pacific. And they've revealed the actual city there. It's San Diego in the Southwest, but we've kept the actual locations of our study in the Midwest, Rocky Mountains, and the Southeast confidential, just to protect all involved. I headed up 3 of those 4 regions. So we had fieldwork teams in these 3 regions that I headed up. And these are the people who did the on-the-ground shoe leather epidemiology work. And they're all exceptional. They were exceptional maternal interviewers. They were exceptional in logistics, in community relations, and school relations, just wonderful folks. And Dr. Haskin, who's on the right there, and the far right, will be talking to you towards the end of this presentation. We've had a dysmorphology team. They're all certified medical genetics. They're all fellowship trained in medical genetics. And actually, Dr. Hoyme to the upper left there is pretty much the world expert on the diagnosis. And he was trained by Kenneth Lyons-Jones, the person who was the co-discoverer of the syndrome. And he has trained, let's see, Dr. Robinson on the upper right there also was trained by Ken Jones. And the other 3 of the other 4 are his former fellows, and they've worked with us for years. All 6 of those people there, including Tamison, let me go back, Tamison Jewett is from Wake Forest, just retired. But there's a Wake Forest connection mark in a lot of these things. What we published for the final prevalence was in JAMA in February 2018. The study was active case ascertainment, where we used all the schools in each of the 4 communities and 4 regions that we were studying. We got written permission from the parents and guardians of all of the first grade pupils that we wanted to study. 59% consented. So we had a higher acceptance rate or consent rate than most people thought we would get. And so having that high a consent rate, we have pretty substantial confidence in what we found. Secondly, we did within each sample a random sample, which gave us even more confidence and gave us the tools to project a more accurate estimate that took into account what conditions might exist in the portion of the population that did not consent, and we were not able to examine in person. So the data were collected in the field 2010 to 2016, and we did 2 first grade cohorts in each of the sites. So it yielded 8 prevalence estimates, which are shown here. Midwestern City on the left, Rocky Mountain next on the right, Pacific Southwestern next on the right, and the Southeastern is in the far left. And you'll hear a lot more about that. Overall, though, the range of the lower bound prevalence was 11.3 to 50.5 per thousand children. That's 1.1% to 5.5%, or excuse me, 5%. And that surprised a lot of people, because the estimates were that FASD was no more common than 1% anywhere in the United States. So if we look at the lower bound mean, you can see the line there that the lower bound mean, the average of the lower bounds, that is, by lower bound, we mean that the rate could not be any lower than this, because our numerator was all the kids that we actually saw in person and did complete testing in terms of dysmorphology exam, a huge battery of neurobehavioral tests, and extensive maternal interviews of their mothers. And we got a very high percent, I think 85% of the actual mothers of the children, to do an interview with us. And that surprised a lot of people too. But the lower bound mean was 2.2%, okay? Now, when we projected from the random sample that we did internally in these cohorts to what we probably have as the real estimate to account for the 41% of the children we were not able to see, the estimates are 31 or 3.1% to 98.5 per thousand, or 9.9%. And there's where the line is drawn for the mean of the true prevalence. What we consider the true prevalence is 6.5%, or 64.9 per thousand. So it's far more common than anybody wants to admit in the United States. The range of the sample means was 2.2 to 6.5%. So some of the summary of the findings for the Southeastern sites. We basically had 2 sites. We had one school system that was in a city in central North Carolina, and we also did a large county which was partially a part of that the one city, and the entire county that it was in, and that county had a couple other small cities in it. All socioeconomic backgrounds. We had suburban areas, we have farming areas, and everything in between. First of all, the question that comes up a lot is there a difference in fetal alcohol spectrum disorder by race or ethnicity? And in the Southeast site, there was absolutely none. The same distribution of fetal alcohol spectrum disorder kids came up that was reflective of the population of the area. So there was no difference, as you can see by the chi-square values there, the probability values to the left that are highlighted in yellow. So moving forward with that, here's the rate of fetal alcohol spectrum disorders in the Southeast. Fetal alcohol syndrome, the lower bound is on the left there. Fetal alcohol syndrome was 2.7, but once we did the estimation factors with the random sample proportions, the fetal alcohol syndrome is basically 3.2 per thousand children. Staying with what we figured to be the true estimates here on the right-hand side, partial fetal alcohol syndrome was 11 per thousand. Alcohol-related neurodevelopmental disorder was 34 per thousand, or 3.5%. Total FASD was 4.9% or 49 per thousand. So the Southeastern site was slightly lower than the total U.S. mean, which was 6.5%, when we look at the what we consider the true estimates. So the low total estimate of FASD was 1.7% in the Southeast. The high total was 4.9%, and it was the second lowest of the 4 regional U.S. sites that we studied. We have demographic and social growth features here, physical growth features. And I don't have a lot of these packed data slides, so don't worry about that. But you can see that virtually all the variables were different between the control group. The control group all came from the same student cohorts of first graders, from the same exact schools, and they were picked randomly. And if after examination and testing, they were developing within the normal range, then they became part of our control group. So these are children developing normally. And when we compare the FAS, PFAS, and ARND children with the controls, they're significantly different. In this case, the sex is different. That is, there are more children in the ARND category who are male than female. But that's really the least important variable here. What's important here is how many of the children were preterm. The FASD kids were more likely to be preterm. Birth weight was lower in the FASD kids, basically, especially the FAS. They were shorter on average. They had lower weight, etc. And their head size, their head circumference was lower, which is not a good indicator for brain growth. And palpebral fissure, the eye openings, which are an indicator of brain growth as well. It was all worse in the, unfortunately, in the FASD groups. And the smooth philtrum and narrow vermilion, the lip configurations, were characteristics of FASD. And it was much different than the controls. When we look at that in bar graphs, we see here the FAS children were the shortest, the shortest, but all of the FASD groups were shorter than the controls. They were, the FAS children were the lightest, but again, all of the FASD groups were lighter than the controls. Head circumference is graphically lower here. And these children actually have true microcephaly, the ones in the blue here, which is a head circumference less than 3rd centile, 2 standard deviations below the norm. And the centiles differed quite a bit. The cardinal features of FAS, which I showed you on the facial diagram, palpebral fissure or eye openings were shorter in the FAS and PFAS group, but not so in the ARND. The ARND children are the least dysmorphic, and this shows you. But the eye openings, again, are a measure of brain growth. Smooth philtrum was most common in the FAS children, but in all cases, the smooth philtrum was present in more of the FASD kids than the controls. And the narrow vermilion of the upper lip, which is, all these are part of the diagnosis of FAS. They proved true, and they were the percentage of narrow vermilion, except for the ARND children, was indeed less. There are many other minor anomalies that we look for that are characteristic of an FASD. All of these were significantly less for the children with FASD. Maxillary arc, that is a measurement around the chin, around the base of the nose, mandibular arc around the chin, ptosis, droopy eyelids, outer canthal distance, that is between the distance of the eye openings and the outer portion. Hypoplastic fingernails show up significantly more. Interpupillary distance, in other words, the distance between the pupils of the eyes. Total dysmorphology score summarizes this. So we basically can say that the FAS children in the Southeast were far more dysmorphic because they had a total dysmorphology score of 15.8 compared to controls of 4.4. And PFAS were less dysmorphic, but yet still significantly more dysmorphic than the controls. And the ARND children had more minor anomalies, slightly so than did the controls. So it forms a spectrum on the physical features. That is, the FAS are most physically affected. The other two, PFAS and ARND, are slightly less affected, but they're much more affected or have more minor anomalies than do the controls. Intellectual domain, the children with FASD did poorer in the general abilities area, including cognition. Verbal ability, the FASD children all did worse. The nonverbal reasoning, it was significantly worse with the FASD children versus controls. Naming operations in the IQ and cognitive tests were not, the scores were not as good for the FASD children. Inhibition is one of the classic behaviors of a child with fetal alcohol spectrum disorder. They were significantly different from controls. Being able to switch your line of thinking rapidly was less, they were less agile in switching their thinking if they were FASD. And speeded naming, another exercise, the children with FAS did a lot worse. Rule breaking behavior was reported to be a lot significantly worse by the parents and teachers for the children with FASD. Reports by the teachers of aggressive behavior was much more common for the children with FASD, and conduct problems in general were more problematic for the FASD children. So the hallmarks of behaviors of children with FASD in the Southeast were like all the other sites, including South Africa: the attention problems, visual motor precision problems, mood regulation, adaptive function, learning, school readiness, and communication deficits all were a problem for the children with FASD. Now, looking at the mothers, what they reported in terms of drinking prior to pregnancy. Before pregnancy, 83% of the mothers of FASD children said that they were drinkers prior to pregnancy. The other 17 probably were not telling the truth because their children all were diagnosed with an FASD. But anyway, among the controls, 49.6% of the mothers said that they were drinking 3 months prior to pregnancy. The number of drinks, so this is whether they drank at all. This is the quantity of drinks. The number of drinks that they had on a usual drinking day was higher at 4.3 per drinking day compared to controls 2.6 when they drank. Pre-pregnancy drinking still. We have 3 months prior to pregnancy. This is based on drinks per drinking day and not the simple yes/no question that the last one was on. But you can see that the FASD mothers were probably the least prone to tell the truth. Anyway, the ARND is 100% of the mothers told us that they were drinking prior to pregnancy. And the reason that they are 100% and these others are not is that in order to make the diagnosis of ARND, where there's an absence of dysmorphology features that are associated with FASD, we have to have their self-report of drinking or another surefire measure to say that they were drinking before a child can be diagnosed with ARND. Number of drinks per drinking day, 3.5 drinks per drinking day was reported by the FAS moms. 4.6 for the ARND moms, and 2.6 for the controls on days that they drank. Frequency of drinking, every day or almost every day, 13% of the mothers with FASD reported that, compared to 7% of the controls. 10%, excuse me, 10% said 3 to 4 times per week. 47.4 said 1 to 2 times per week. And all of these are more common for the FASD, except for 1 time per week. In South Africa, most all of the children that we see with FASD, their mothers only drank 2 days per week. So you can produce a child with fetal alcohol spectrum disorders with 2 days of drinking per week. Other drug use in the Southeastern sample during the index pregnancy was 40% for the mothers of FASD, and that is they 40% smoked versus 19% of the controls. 8.9% of the mothers with FASD reported having used cocaine during their lifetime or during pregnancy, and 2.8% of the mothers said they used marijuana. However, if we look at the comorbid use of alcohol and marijuana among the FASD moms, 14%, actually 15% of the mothers with children of FASD used marijuana and alcohol during the index pregnancy. So we're concerned about that because, and this is a good take-home message for prevention, both alcohol and marijuana downregulate the same genes that have to do with development of the brain and the midface and the cranium. It's called sonic hedgehog gene, and there's several others, but they are key to brain development and midface development. So if you have an individual smoking marijuana and consuming alcohol, the children are probably at double risk to have FASD. Raises questions about legalizing marijuana, but I didn't say that. So when we did adjusted binary logistic regression, if an individual in the Southeast is drinking 3 drinks per drinking day, 4 drinks per drinking day, or 5 or more drinks per drinking day, the odds ratios of having a child with FASD are 17.6 for 3 drinks per drinking day, 12.7 with 4 drinks per drinking day, and 7.8 odds ratio for 5 drinks per drinking day. Now, probably this should be reversed, but it's not, because what happens is we found that mothers at this particular site and in the United States in general, and to some degree in South Africa, the mothers report very accurately yes or no that I drank during the pregnancy, but the number of drinks that they report usually is underreported, and they tend to cluster at 3 and 4 drinks per drinking day, even if the mother's drinking substantially more. So the point is that between 8 and 17.5 times odds ratio, the diagnosis of an FASD is more common. So if you have even drinking prior to pregnancy, which often predicts accurately what drinking during pregnancy is going to be, if you have people who report drinking 3, 4, or 5 drinks per drinking day, even prior to pregnancy, their odds of an FASD diagnosis in their child is 7.8 to 17.6. Prevention is the way to go. Gestational timing, we looked at first, second, third trimester timing, and basically 24% of the mothers with of children with FASD reported that they drank first trimester. 4.4% of the mothers of the controls reported that they drank. 3.4%, 3.4 drinks per drinking day is what's reported by the mothers who drank in first trimester who had a child with FASD. 5.2. So there are drinking mothers in the control group who gave birth to children who were developing in the normal range. And they drank some substantial amounts. So drinking doesn't always produce a child with FASD. Frequency, the mothers of FASD, with the exception of 1.1 time per week, they all reported that they drank more days than the controls. Second trimester, 17.8% of the mothers with FASD reported they drank, which is probably underreported. 1.6% of the controls said the same thing, that they drank. And the number of drinks per drinking day, 1.7 and 6.3 for the FASD moms and controls. So the mother's physical, so the distal, excuse me, let me back up. Those data that I just showed you are for proximal risk, that is exposure to alcohol and drugs. We look at a number of distal maternal risks that are present in mothers who have a child with FASD, and they are important for prevention programs. Just as getting women to quit drinking during pregnancy is important, these other characteristics we found to influence the severity and the likelihood of an FAS diagnosis. Physical characteristics, height, weight, mother's body mass index, and head circumference all translate to an association with FASD, increased likelihood of an FASD. Childbearing variables, gravidity, parity, that is the number of pregnancies they've had before, parity, the number of live births that they've had, miscarriages, previous therapeutic abortions, all of these things influence the severity or the likelihood of a child with FASD. Socioeconomic status, the most important thing that we found there is educational achievement. The mothers who have high educational achievement up until recently appear to be the least likely to drink during pregnancy. That seems to be changing. A lot of very well educated middle and upper SES mothers have reported drinking in recent years, and there was one biomarker study done in Texas that showed that actually drinking was really quite common in women with substantial education and high SES. So I got to speed it up a little bit here. Some other maternal risks that show up: general depression, not postpartum, history of epilepsy in the mothers, neurological conditions all showed up as more common in the mothers with FASD in the Southeast. Preterm birth, the children with FASD was more common. Fewer children with FASD live with both parents or birth mother, although it was much higher in this active case ascertainment study than most people thought it would be. Only about 15 to 20% of the children do not live with both parents or with their birth mother. Unmarried status of the mother creates, or it's associated with higher risk for FASD. Weak when pregnancy was first recognized. What happens is a lot of the women in all of the US sites did not recognize they were pregnant until many cases 7th, 8th, and 9th week of pregnancy, and therefore they did not go to prenatal clinic prior to that time. And often drinking continued through that period. So there are a lot of first trimester exposures because of that. So here's when the week when they first recognized they were pregnant. 8.3 weeks into the pregnancy for the mothers with children with FAS. 6.9 for PFAS, 8 weeks for ARND, and the controls, it was 5.7, 5 weeks and 5 days or so. The mothers were significantly more likely to have preterm birth if they bore a child with FASD that was diagnosed with FASD. The birth weight of the children, except for PFAS, which is unique in that there's not major growth deficiency ever with PFAS kids. But anyway, the birth weight was lower in most of the types of FASD. And child living with the biological mother with FASD, it was 77%. So I misstated a little bit earlier. Child living with the biological mother and the controls, it was 94%. Fewer of the mothers of children with FASD are married. More of the mothers of children with FASD were divorced, single, or separated. And 43% were living with partners, unmarried, compared to 24% of the controls. Spirituality is the last variable I'm going to cover in distal, and we'll be moving on to the next section. Spirituality ranking has proven to be important virtually everywhere we've worked, especially in South Africa. That is, mothers who rate themselves as more spiritual tend to have fewer children with FASD. Here in the Southeast, there was a significant difference. The mothers who had children with FASD ranked themselves between 1 and 10 on the spirituality scale of 5.6, which is significantly lower than the mothers of the controls at 6.9. When we compare the 4 regions in the COFASP study, has been shown in a number of the Pew religious surveys in recent years, there is an increasing number of people who consider themselves unaffiliated to any major religion. And it was the lowest in the South, in the Midwest. It was next lowest in the Southeast. It was highest in the Rocky Mountain region. And it was almost as high in the Southwest region. This is almost identical to the rate of fetal alcohol spectrum disorders. Midwest had the lowest, Southeast was next lowest, Rocky Mountain had the highest, and this Pacific Southwest had the next highest. And these two were substantially higher than the other two. The Pacific Southwest prevalence of FASD was 8.5%. The Rocky Mountain one was close to that. I think it was 8.7%. So it's interesting. So when the mothers actually reported their importance of religion in their life, 9% in the Midwest said it was not important, 8% said it was not important, but in these other two, 15% said it was not important. So it's interesting how that translates to associations with prevalence of FASD. Now I'm going to turn it over to Julie, and she's going to do the fun part of all this. She's going to talk about how we move the field forward with epidemiology and how some of these studies might relate to prevention.
So with all of that context that Dr. May has just provided us, we can begin to think, how do we take these risk factors and all of this information and actually translate that to prevent FASD in the future? And so I think the first question that we all would have is, well, why don't women who are pregnant quit drinking? And so this was a study done by Melissa Watt and colleagues. Melissa is based at Duke, but what they did is they went into alcohol serving venues in Cape Town, South Africa, and just asked that question: why would women continue to drink if they're pregnant? And they did a qualitative analysis, and what they found was the majority of pregnancies were unplanned. And so, as Dr. May alluded to, there can be a lot of exposure during those first 2 months of pregnancy before women even realize they were pregnant. They also found that women were drinking because of the stress And they use it as a coping mechanism to deal with the abuse, the trauma, or other adverse social events in their lives. And that was really an important thing for them to have some mechanism of dealing with that stress. And alcohol met that need for them. They also reported that the drinking venue was their social structure and their social support, and they really needed to go there and drink with their friends to relax, to have that sense of community that they weren't getting from other institutions. And then finally, they also found that these women had a sense of invincibility. Well, I'm too blank, it won't happen to me, I'm too young, I'm whatever. And so they didn't think alcohol could have a negative impact on themselves or potentially their child. And so what the authors concluded in this study, and a direct quote from their conclusion, is these findings highlight an attitude behavior gap and suggest that positive prevention attitudes, or knowledge alone, are insufficient to elicit an FASD preventive behaviors. And this shouldn't be surprising to people who work in the prevention field. Any one of the health behavior models would say knowledge alone is insufficient for behavior change. And we really need to be thinking about, how do we address the underlying issue? Why are people drinking? How can we correct that so the downstream effect would be less drinking during pregnancy? Or how do we include social support and social structures into our intervention messaging in order to eliminate or prevent FASD? So the next question we might be asking ourselves, well, okay, we didn't prevent exposure. Do we need to think about how we do secondary prevention with boys or girls? Are there any differences in their outcomes? And so we did a study looking at this, and by and large, alcohol affects both males and females the same. We did find that if you look at sex ratios, if mothers reported drinking heavy amounts, such as 6 drinks per drinking day or more, boys were less likely to survive prenatally and at year 7. Now, we couldn't conclude whether that was a biological reason why males were underrepresented, or if it was a social structure and just things happened in life. But regardless, males tended to seem to be more at risk for not surviving. But those women and children, girls and boys who did make it to 7 years of age, the girls did appear to be slightly more impacted in terms of their overall dysmorphology and their physical features, and slightly worse off in terms of performance. Sorry, there was a comment that came up. So overall, alcohol affects both boys and girls the same. It could be that girls are slightly more affected, but the take-home message here would be that alcohol in general is just bad for the fetus and for the development of children. So then you might be thinking, okay, well, how do we determine who is exposed? Do we have a way, a tool? Because, okay, if women aren't necessarily forthcoming in their alcohol exposure, could we have a tool that would help identify this? And what we found was that when we looked at 2 biomarkers, phosphatidylethanol from blood spots or nail samples at the glucuronide, when we compared if they were positive on one or both of those biomarkers, that was consistent to what women were reporting to us, whether they were drinking or not, yes, no. And so we do have very easy to use, easy to collect biomarkers that could be a way that we could identify women who have been drinking during pregnancy. And this could be very important for individuals who work with populations that routinely collect infant cord blood or finger sticks as part of prenatal care. Potentially we could implement a system that we would then test those anonymously to at least get an idea how many people in my population could be exposed to alcohol and therefore the fetus being negatively impacted. Another thing we should be thinking about messaging wise is, okay, we'll assume we've gotten the message out, alcohol and pregnancy don't mix. Well, what about alcohol during the breastfeeding period? Is that a time that we need to be concerned about? And do we need messaging specific to the breastfeeding period? And so when we looked at this data in South Africa, what we found is when we controlled for prenatal alcohol exposure and the child's diagnosis, women who exposed their child to alcohol during the breastfeeding period had children that were lighter, had lower verbal IQs, and had more physical anomalies. And so that would suggest that alcohol during the breastfeeding period can have a direct effect on the child, and therefore we should be thinking about messaging specific to the breastfeeding period that these things don't mix. And we actually found that if a mother reports drinking during the breastfeeding period and breastfed, that she was more likely to have a child with an FASD diagnosis at 6.4 times as likely. And that overall we could conclude that approximately 2% of the likelihood of an FASD diagnosis could be attributed back to the breastfeeding and simultaneously using alcohol during that period. And so another question we might be thinking about is, okay, we've now got messaging specific to alcohol exposure during pregnancy. We've got messaging about alcohol and breastfeeding. Were there things that we could have done during pregnancy, other messaging techniques we could use? And so we looked at a study that looked at dietary intake and to see perhaps we need to be thinking about how supplementation or how having a good, adequate diet might be important for women who are pregnant in order to reduce or eliminate the susceptibility and severity of having prenatal alcohol exposure in a FASD diagnosis. And so what we found in this study was that more than 50% of the women were below the recommended intake on a variety of nutrients and vitamins. And we did find that mothers of children with FASD reported significantly lower intakes of calcium, a fatty acid, riboflavin, and choline. And these could be very important for overall child development. And so if we could think about how we ensure that these women would have adequate intakes of these key nutrients, that could be a very important step in preventing some of the adverse effects of prenatal alcohol exposure. And so we did a replication study, again, looking at diet to see if that was something that we could intervene upon or should be intervened upon. And what we found here was that, again, most of the women were inadequate, really reaffirming the idea that we need to consider diet and overall intake as a preventative way of reducing the risk for the adverse effects of prenatal alcohol exposure. And then a few other things that we were thinking, okay, so maybe we missed the mothers during pregnancy, maybe we didn't have the opportunity to intervene upon them. Are there early life indicators that we could be using in a post-pregnancy population or in the postpartum period that would help identify mothers and children who might benefit from being monitored more closely in order to initiate early intervention services? And so we were looking for some of these key findings or factors or risk factors. And one of them we looked at was small for gestational age. And what we found is that when we looked at children who were diagnosed at age 7, 18.4% were preterm, 51.4 were small for gestational age, and 5.9 were both preterm and small for gestational age. And so when we did regression models, we were showing that the odds of having a diagnosis was increased by almost 2 times if you were in fact born small for gestational age compared to not being small for gestational age. So this could be an early robust indicator for an FASD diagnosis. And so if you have a population or you have a patient before you who's small for gestational age, and there are some of the other maternal risk factors that Dr. May had spoken about, that might be an indicator that this might be a family we need to target more closely to follow and make sure this child is meeting the developmental milestones that we would be expecting. And then finally, just one more postpartum maternal risk factor we can consider in these populations, just maternal weight. It's a variable that many clinics and research studies would collect. And so it's an easy thing that you could just say, hey, this might be a risk factor that we need to consider as well. So in this study, we looked at if we measured the weight postpartum, was that associated with better child outcomes? And what we found was that maternal weight was inversely associated with dysmorphology. So that says the higher the weight, the lower the dysmorphology score. So in this population, which I should mention was in South Africa, so a population that we know has nutrient insufficiencies and is a high-risk population for a variety of reasons. In this particular population, having a mother who was low weight might be an indicator saying that this child could be at risk for more severe effects of prenatal alcohol exposure. We did a similar analysis looking at, well, what about the cognitive outcomes? And again, we were showing that having a higher weight, the infants were better off both physically and cognitively. And I should note the study was only through 9 months of age, so we can't really comment on the long-term increase or decrease or positive effect of maternal weight, but it is something to consider in certain populations. Maternal weight might be an important variable to consider as well. And so I'm going to conclude here with just a few summary slides, a picture slides, and this is a picture taken in one of our communities in South Africa. And it's on the FASD Prevention Day, which is September 9th every year. And what the sign says is it's 100% preventable and 100% irreversible. And so while getting the knowledge out of FASD prevention and alcohol and pregnancy don't mix, it's important that we do more than just knowledge. It's important to think how we get the community involved and how do we really address other factors, be it the risk factors that Dr. May alluded to or some of the ones that I've spoken about here, to really prevent FASD. Because as we showed back in 1981, when the Surgeon General first came out with his report and said that there is no known safe level of alcohol exposure, we've known that for years, and we now need to continue to think about how we can use epidemiological data and the risk factors we described here today to then implement other prevention efforts in the future. And so with that, we'll say the quest continues, and I think we'll open it up for questions. I think I am going to stop sharing.
Well, thank you so much, Julie and Phil. This was amazing. What a great comprehensive education in FASD. So please go ahead and put questions in the chat, and I will. I think I'll start with a couple of questions to get the ball rolling. And you know, our crowd, we're preventionists. We're all interested in prevention, and so you know, I really appreciate Phil's sort of tour of the epidemiology and biology of FASD, but also Julie's you know, look at different aspects of prevention. And you know, I was going to ask a specific question, Phil and Julie, but let me ask a broad question and maybe hear from both of you. And that is, where do we have the most leverage for moving the needle at the population level on the incidence of FASD? So, you know, we heard discussion of education of, you know, traditional, conventional education of pregnant women, but we also heard about the limitations of that, you know, that'll only go so far if you don't address the reasons for drinking. You know, it was fascinating to hear about, you know, the contribution to the public health problem of the contribution that comes from women not knowing they're pregnant for 8, 9, 10 weeks or more. So, you know, is that an important point of leverage, and how would we go about that? You know, I have to say, you know, it was interesting to hear the Surgeon General's report, but about there being no safe level of drinking. But I wonder if there's a harm reduction message, because when I looked at those odds ratios for one drink, you know, one drink, the odds ratio was less than, you know, than, you know, people, the controls who don't drink. It's under 1. And, you know, for 2 drinks, it was 1.4. So has anybody been experimenting with messaging around, you know, what a safe level or, you know, might be, or where in the pregnancy, which trimester it's most important to not drink. You know, the stuff about vitamins was fascinating, and so maybe that's part of the solution. And then educating others. You know, I don't know. You've done some work, Phil, on educating server training around serving women who are visibly. You know, you get into all sorts of issues about stigma and societal attitudes about that. So I think I said I was going to ask a simple question, but
you asked 10.
I've asked 10, and so maybe my question is, what do the two of you think are the greatest points of leverage for our audience who are concerned about prevention?
Well, first of all, I think that we as public health officials need to get out the message of how common this really is. And when we published our USA results in 2018, that was we're only the second nation in the world to have a national figure that has been determined by active case ascertainment. In other words, the most accurate way of doing it. South Africa is the other one, and we had published that much before. Since then, there's been a study in Canada, in Ontario, that found similarly high rates. But the point is When we published that in 2008, we got a real splash for about 2 weeks. It was really disappointing. We were on all the major news services. The quality of the articles varied greatly, including about a month after we published it. Wine Spectator did one that basically said, well, they're not really sure of this. They had interviewed us and everything, and it was extremely negative. But the point is that we in the United States have probably the best empirical study in 4 different regions of any country in the world. And I think if we can somehow leverage that to get the word out that fetal alcohol spectrum disorders, if our high estimate is correct, and it's very conservative, I have to tell you that, both of our estimates are conservative, but if that high estimate of 6.5% of the children in 1st grade are FASD, that's 3.5 times what the autism rate is, 1.8. You know, so, but autism gets lots of money. There's lots of prevention out there for autism. We're an orphan. So, I mean, I think that's a really valuable tool. If we can figure out as preventionists how to message that in a way that is acceptable. And we tried, we started the first from New Mexico. We started the first national program of prevention of FASD in 1984, National Indian FAS Prevention Program. And we did that through training trainers. And we told the trainers, get the message out about how alcohol during pregnancy causes this. And right about the same time, the Surgeon General's first message had come out. But you're right, there is a point where you aim for abstinence, because that would be total prevention of FASD. But if you get harm reduction at the 1, 2, 3 days drinking level a week in the first trimester, you can do that. And we have done that in South Africa. We're finishing up the last draft of a case management article where we can show that our case managers influenced the mothers in a way that their children were less severely damaged. In other words, there were fewer children with FAS that participated in the case management. But there are the reason with all these distal risk factors that we show in the Southeast or in any of the places where we work, there are a lot of ways to impact it. You mentioned server training, and in New Mexico and Oregon, we had an NIAAA grant to train trainers in several counties in New Mexico, including Bernalillo County, where Albuquerque is the biggest population. And the owners of the bars, the bartenders, and even in some cases, the bouncers were trained. We went and gave them a 2-hour training on FASD and how to prevent it, and how that they might push non-alcoholic drinks if an individual ordered an alcoholic drink and was visibly pregnant. Use it as a teachable moment. We gave them pamphlets if they wanted to hand them out. And some of them took it very seriously to the point where we showed that there was indeed some success in the server training. A lot of states do mandate server training now, but I don't think it's often followed. New Mexico does. I think Oregon still does. But server training is one good way to do it.
While we're waiting for Julie to jump on, I do want to let everybody know, if you don't want to type in a question, feel free to raise your hand. It's down on the bottom, the little hand, and when it's time, I'll unmute you and you can just ask a question directly. Go ahead, Julie.
Thanks, Kristen. And I'll just add that Heather offered, in South Carolina, we have an FASD portion that has been added to our merchant education as well. So it seems to be spreading.
Great. We started first with point of purchase posters that alcohol and pregnancy don't mix. So every liquor store in New Mexico, every bar in New Mexico had to post that. And I have to say it's been marginally effective.
Well, it's a low-cost intervention, right? So
Sure is.
if it's been even marginally effective, then that's something of a win, I would think.
Some
So, Julie,
FASD prevention programs have even put posters like that over urinals in the men's bathroom in bars and restaurants. Alaska, they do that. In some places, there are a lot of different places to get the message out. But Julie, your turn.
Just to dovetail off the server training, it's important to think not only in alcohol primarily serving venues, but alcohol is available in a variety of other locations, and women are going to drink a casual drink here and there, not necessarily at a bar. They might be doing it at a venue of sorts. So it's important to think server training is one mechanism, but to be careful not to limit what we define as the high risk places that we need that kind of training.
thank you. I wonder, Heather, would you like to come on? It looks like you're quite familiar with the situation in South Carolina in terms of merchant education and a statewide legislative proposal. But while we're waiting to hear from Heather, she mentioned that legislation has been pushed to make merchant education mandatory. I think in South Carolina, it's taken a back seat since the pandemic. But that would be huge for all merchants to have FASD training.
Can you hear me?
Yes,
Heather,
thank
go
you.
ahead. Heather, you're live. Go ahead.
My knowledge is kind of limited, but I want to say that it's called Allie's Law. And I mean, it's been kind of several years in the making. Again, it was in legislature whenever COVID came on the scene, and we were kind of hopeful that it would get some traction, and then more important things, I guess you could say, kind of came up. But it would require all merchants that serve alcohol specifically to have to take our Palmetto Retailers Education Program. And so in the process of pushing that, they added the FASD portion, as well as a portion on sexual assault, how to recognize if a drink has been spiked, et cetera. But that is kind of hopefully coming soon, once that kind of gets some more traction. But that's really exciting kind of on the front. If we could just get that across the board, I feel like that would make a really big impact as well.
There are two national organizations which have now merged that are solely for prevention of FASD. It used to be called NoFAS out of Washington. It's now merged with Minnesota NoFAS, and they go by FASD United and Proof Alliance.
Excellent.
You can
I'm sorry,
probably
go ahead.
Google either one, FASD United and Proof Alliance, and they would have a number of resources that they could share with you on prevention ideas.
Excellent. What about our obstetricians? To what extent has counseling and education about drinking become standard and expected for for prenatal visits and well child visits, for that matter, given what you presented on breastfeeding?
It's highly variable, Mark. I think there is a goal out there that every individual or couple presenting to prenatal clinics would get some counseling. And there are pamphlets out there. NIAAA publishes one, and I believe they have several varieties of the pamphlet about alcohol and pregnancy, not mixing. But the literature that have evaluated those programs show that it's very mixed, and that a very high percentage of the women who go to prenatal clinic report that they got no education or information about FASD there.
It seems like that's an area ripe for advocacy and prevention efforts. And
In
so
South Africa, we give all the people that are in our programs 3 pamphlets. One that describes how alcohol and pregnancy should not mix. A second one is a very simple pamphlet on the stages of embryonic and fetal development. And that's an eye-opener to a lot of our South African clients. And then a third one is how the male can support a healthy pregnancy.
Heather is unmuted again. She had another question.
Yes, actually, it's kind of I guess a plug, but we about a year ago we worked with the South Carolina Collaborative for Fetal Alcohol Spectrum Disorders, and got a webinar recorded. Actually, it's 2. One of them is for the audience of like a pregnant woman. The other one is called FASD Implications for Practice, Problems and Interventions. And it is specifically targeted at physicians and healthcare workers because, it has a little bit more of the jargon that, they would understand. But they're on our YouTube channel. Feel free to look at them, share them with any kind of healthcare practitioners or anything like that. But I work at a facility called Westview Behavioral Health Services, and I can put that in the chat. And again, I'm not trying to, I'm just trying to share a resource that we recorded about a year ago. So I can put in the chat where I work, but please feel free to use both of those webinars in whatever way that y'all see fit. But I mean, we definitely want to get the information out there as well, because I mean it's invaluable information. So I'll put our YouTube, well, I mean, if you just search in YouTube Westview Behavioral Health Services, it'll come up our page. And we don't have very many videos uploaded, but both of those are on that page as well.
Thank you, Heather. So I have one last question I'd like to ask. So you're both affiliated with, you're both in a Department of Nutrition at UNC Chapel Hill. And I wonder if we could be doing much. So the slides, about vitamin deficiencies were so interesting. Can we be doing more in that regard, either through education, but also through policy, right? There have been huge, I think one of the signal advancements in public health was the addition of niacin. Was it niacin to bread? But is there more we should be doing in terms of either education or state or even national policy with respect to nutrition related to FASD prevention?
Dr. Haskin, take it away.
The obvious answer would be yes, there'd be more to do with nutrition. I think specifically right now in the United States, the prenatal vitamins is the standard of care, but really thinking about what are in those prenatal vitamins. Do they actually contain the micronutrients at a level that are not going to be harmful, but actually would be sufficient to overcome any deficiencies the mother might have and therefore pass on to the child? And so we're really thinking about that quantity. We could also be thinking about, are there certain interventions? So there's been work done by a variety of different groups, including Jeff Wozniak at Minnesota and Tina in the Ukraine, focusing on choline and say choline supplementation. And could that be a way to improve the exposure or improve if the child had been exposed to alcohol during pregnancy?
Thank you, Julie. And I want to acknowledge a message from Barbara, who mentions that she has several birth defects and lists them, and her birth mother was an alcoholic. So our families of alcoholics are certainly affected by this. Well, I think with that, if there are no more questions, I want to thank both Phil and Julie for a wonderful presentation, eye-opening presentation. They've offered a couple of resources which we will post following the webinar